Today we should be talking to Dr. Sukhvir Wright, a Wellcome Trust Clinical Research Career Development Fellow at the Institute of Health and Neurodevelopment at Aston University and an honorary paediatric neurologist at Birmingham Women's and Children's Hospital. Suki's particular passion and focus in her work is trying to improve the developmental outcomes of children affected by immune-mediated neurological disease, mostly immune-mediated seizures and epilepsy/encephalitis. If you're interested in learning more, stay tuned for the chat with Suki. Subscribe and press the bell below to receive notifications of the future interviews we will hold on this channel.
I am a paediatric neurologist, so I am a paediatrician and I specialise in looking after children with brain diseases and disorders. So I've been doing that for a number of years, but at the moment, and what I have done over the last, I think it's 5 years. 5 years is actually mainly focusing on research now. So the majority of my time is spent in the lab, running a small lab, and also combining that with about half to 1 day a week clinical work in the hospital. So my lab research is in Aston University, and my clinical work is at Birmingham Children's Hospital, and very nicely they're just across the road from each other, so I can just nip across the road to both places. So ideally, so it's a great combination at the moment.
What's it like having that combination? So rather than just having one thing to focus on or one role to focus on, you have to have both, or tell us how they complement each other, I imagine.
They absolutely do. I think it's a real privilege to be able to do both. To be able to see patients with the diseases that then know that you're going to go back to the lab and try and not necessarily, try and cure, that's obviously the ultimate aim, but, try and understand a bit more about them and then hopefully bring that research back to the patients that you actually see. I think it's only when you see the patients that you realise that a lot of the problems that they're facing aren't just the acute ones that you see in clinic, but as you see them over time, you can see that actually there's long-term effects of some of these disorders that we're researching related to epilepsy. So it's great to be able to do both because the patients inform the research, and then the research hopefully can inform the patients and hopefully improve their outcomes, which is our goal. But so I guess it's fantastic in that sense to be able to do both. I think you sometimes feel that you're a bit torn sometimes because my clinical work is limited. You want to be able to do more, but you've also got the responsibility to funders and the lab group to obviously be able to do that as well. So it's kind of reminds me of when I first went back to work after having kids. You felt guilty going to work, and then you felt guilty being at home because you were not at work. So it's a balancing act like everything, but at the moment it's really good.
This disease or disorder, tell us about it, the primary one that you're looking into, and how epilepsy is kind of like a symptom of that, tell us about it, a bit more detail if you can.
Sure. So I research into autoimmune associated epilepsies, and particularly epilepsies that may be a result of antibody or autoantibody mediated neurological disease. So antibodies, as I'm sure they're kind of our molecular soldiers in our kind of immune army. They sort of protect us from viruses, from bacteria, and most of the time they do their job well in protecting us, but occasionally they get a bit distracted. And that might be because of a different virus, it might be because of a tumour or something else going on in the body. And instead of therefore kind of protecting us and our vital organs, they start attacking them because they get confused and think they're foreign and they need to attack them. So these antibodies are called autoantibodies. And so I'm interested in the diseases when these antibodies target the brain and particular brain proteins. And when this happens, we get a condition called autoimmune encephalitis. And one of the main symptoms of that is epilepsy. Patients, children and adults will display changes in behaviour, seizures, abnormal movements. So it can occur at all ages. And epilepsy is quite one of the common symptoms during the disease, but some patients, when they've recovered from the kind of acute bit, also be left with seizures as well. So that's what I'm looking into. So I'm looking into why these kind of autoantibodies cause seizures, and if there's anything we can do to just kind of, try and stop the seizures and maybe then the other symptoms as well.
So do we have any idea or any sort of inkling or suspicion of what may cause these antibodies to poke their nose in, faff about with our brains?
Yeah, absolutely. No, again, really good question. So interestingly, the most common one is called NMDA receptor antibody encephalitis. And this was first described in young females. And these young females had a tumour called a teratoma, an ovarian teratoma. Now, teratomas are quite unusual tumours in that they're kind of made up of different types of tissue. So they can actually have bits of hair, bits of teeth.
I've read about these, and it looks so weird. You're like literally seeing bits of skin, hair, like a tooth poking out there, and it's like, whoa. Yeah.
So those, but they can also have a bit of neural tissue or kind of brain tissue. So basically, your immune system goes, "What's this?" It's thought. So one of the hypotheses is that your immune system thinks, "What on earth is this?" And then starts making antibodies to attack it. And some of those antibodies will actually be directed towards the NMDA receptors in the brain tissue. And if those antibodies therefore can get into the bloodstream and into the brain, then they can actually attack your NMDA receptors in your brain, as well as the ones that they're trying to attack in the tumour in the ovary. So that's one of the reasons.
And so I presume, though, this type of, I've heard of other forms of encephalitis that men can get, but I guess it wouldn't be an ovary induced or a tumour of the ovary. So how would that work?
So there are other tumours that can cause it, so other lymphomas, etc., that have been associated. And quite a lot of the time, we don't actually know why. In children, actually, what we've realised over the last few years is that children might actually have a viral encephalitis. And again, seizures are a big part of that. So, for example, herpes simplex virus encephalitis. And then they recover from that, and they do okay, and they've had their antivirals, and then they kind of relapse, and they can relapse with abnormal movements or seizures. And you test their spinal fluid. There's no evidence of virus. So, and what we found is that actually some of those children have actually developed NMDA receptor antibody encephalitis after a viral encephalitis. So the theory there is that the viral encephalitis has kind of exposed some of their brain proteins when it was active. And again, that has sensitized the immune system to produce the antibodies. And then, once they've sort of recovered from the viral encephalitis, those antibodies, have multiplied and then caused the kind of NMDA. So that's another reason. So it can be tumors, it can be viruses that trigger this. There may even be a genetic susceptibility, and quite a lot of groups are looking into that as well. That you could have a susceptibility to kind of autoimmune disease or other things that can make you just more at risk of getting these kind of disorders.
Yeah, so you're making me think of herpes simplex. You're making me think of, obviously you just mentioned that, but also I read a paper about HIV and how that can cause encephalitis as well. Is that right?
Yes, that is right. Yeah, absolutely. It can cause encephalitis. Yeah, so a number of different viruses. And actually, there's also been a case report of patients developing NMDA receptor antibody encephalitis after COVID-19. As well.
Interesting.
But very, very few. Very, very few.
It's all about numbers, isn't it?
Yeah. But viruses are definitely a trigger. Yeah.
So how long have you been studying this?
A long time. Over 10 years, I think. Yeah, well, I think the first patient I saw was about sort of 10, 12 years ago when I started training that had this encephalitis. And then basically so we saw a couple of patients in Birmingham Children's Hospital, and then, this wasn't anything like we'd seen before. And I think when you're a doctor, you never think that you're going to see a new disease, as it were, because these have only actually been really characterized over the last 10, 15, 20 years. I think there were different names for this disorder. It probably always existed, but nobody knew what the cause was. So now that we've identified the autoantibodies, we know what the cause is. So when these cases started happening, we thought, how many are there in the country? So we organised Birmingham Children's Hospital. I'd only just started as registrar, and they said, why don't you do a national survey of the UK and find out? So that's how it started. So we set that study, tried to find out how many cases in children in the UK, and then that led me to meet my supervisor in Oxford, Angela Vincent, and then then did more research with her, and then carried on from there.
So what have you learned, like, in the past decade? I can't believe I'm saying that, decade. It sounds like forever, but it just goes so quickly.
Yeah, absolutely. What have I learned about this? Yeah. So what have we learned? So I think we've learned a lot about how the NMDA receptors in particular, how they cause disease. So when the antibodies bind to the kind of important brain proteins like this receptor, they either kind of bind to it and they kind of hold hands across all the receptors and then basically take them below the surface of the cell membrane, which means you get a loss of these receptors. So you just get a loss of those, which, is obviously, you need those receptors, so you get a loss, and that leads to quite a lot of problems. So we've learned that that's probably what the NMDA receptor antibodies do. We've been focusing a lot on, so why does that actually cause seizures? And so we've been looking at that. And then most recently, we've been looking at so the normal treatment for these disorders is to try and get rid of the antibodies in the circulation, all antibodies. Unfortunately, you can't just specifically weed out those ones. So a lot of the therapies that we have, which are effective, the immunotherapies, try to stop production of antibodies or remove them from circulation. But other groups and our group are looking at maybe, because as I said, as these receptors kind of are lost below the surface, can you kind of bring some back if they're there and try and rebalance it? So we've been doing some work on that and found that we could do that in the dish. So we need to see if we can do that in real patients' brains. Yeah, so that would, because I think that would help to rebalance the system so that you wouldn't get the seizures, and it just might help the recovery.
This encephalitis and all the stuff that goes with it. Of course, the epilepsy is just one of the diseases incurred by this, or side effects. What's the other stuff that happens generally, or what are the other possibilities as a result of this?
Probably the main symptoms, particularly in adults, is actually neuropsychiatric symptoms. So often patients can present with like a psychosis. So that's definitely one. And what's interesting is so schizophrenia, which is a psychiatric disorder, has the same kind of theory underlying as to why it occurs, that it's like a hypofunction or a loss of these NMDA receptors. So they might share the same sort of underlying cause for that sense. But obviously schizophrenia doesn't necessarily lead to the other symptoms, and it's a different mechanism, but the theories are similar. So that's why you probably get the neuropsychiatric symptoms when you lose your NMDA receptors. You get the seizures, you get abnormal movements, so movement disorder. We've described some children who get a real change in behaviour, which isn't like a psychosis, but they can kind of stop talking and almost become mute, and catatonic as well. So you can get all sorts of different symptoms. And sleep gets majorly disrupted as well, particularly in the children. But I think the great thing is, the more that we know about it, the more people are recognising it, because the one thing about it is that it is potentially treatable, which you can't say that about a lot of neurological diseases.
Yeah.
If you can identify it early and treat it, it's treatable, which is rare.
Would you say there's a sort of average age that a child might develop this?
For NMDA receptor antibody encephalitis, it's usually so the most commonly affected are young women. It's mostly young women. So sort of teen and early adulthood. Yeah.
So much for equality, eh?
Yeah, no. But some of the other antibodies, for example, to a protein called LGI1, which does cause hundreds of seizures a day when it first starts, actually affects older men in their 60s. So there is a bit of balance.
Again, so much for equality,
Yeah.
Gosh, it's so amazing how these diseases affect our brains. Just look like tiny little bits of squishy gunk, but they're such fragile little almost creatures, aren't they? And all you need is like a bit of skank or a little chemical imbalance, and it's like,
Very good description. Absolutely right. I mean, you literally need, to lose these receptors in a tight, maybe just a small pool of, brain cells. Yeah, and that's it. And there's a book written by a journalist who actually got an MDA encephalitis called Brain on Fire. And I would recommend that because it's a great title, and it really does kind of, like you say, just explain suddenly you can get all these symptoms.
I was talking to Gavin from Aston University, and when he was referring to slices of brain like French toast, I was like, oh, that's nice. But when he was also saying, though, that isn't it really quite extraordinary that more of us don't have epilepsy and that the brain isn't more mucked up than it is because it's so fragile?
I agree, and particularly children's brains as well, because they're going through such amazing development and changing all that time. And they're so vulnerable to any insult, but and we still don't know why one child, so for example with MND encephalitis, might do really well if they, whether or not they've had seizures or what symptoms, but another child will do really badly, and they might have been treated at the same time, but they'll end up with different outcomes. So we really want to try and improve those. So there's so many things we don't know, and yeah.
Do you think the severity of this disease is at all impacted by a child's mental health and upbringing, support that they may or not have? Because I know, like with not that there is such a thing as a regular epilepsy, but we know, like for instance, if you've got a supportive family, then you're going to have better brain development, and then going on, you could even be less likely to have seizures, even if you have epilepsy, right? So is there anything sort of to do with care that can impact a person's or child's likelihood of developing this form of encephalitis and their recovery?
That's a really good question. I don't think in terms of contracting it, but I definitely think there's an impact on recovery, because I think what we're seeing now is that actually you need neuropsychological intervention really, really early on. So studies are coming out, because I think, like I said, because it was a treatable neurological disease, everyone's been really hot on, right, as soon as the patient gets ill, we'll treat them with the immunotherapy, we'll get rid of those antibodies, they'll be fine. And the kind of rating scores that we have to see if they're fine are quite crude. So they'll say, well, their outcome is, is good, it's a good outcome. But actually, if you probe that a bit more, it's not such a great outcome. A lot of these children and even adults, are not doing as well at school. They are struggling. They haven't got back to where they were, even though they're kind of walking, talking, doing all their activities of daily living. That's kind of classed as a good outcome, but actually there's a lot more underneath. And I think it's that those hidden effects of epilepsy as well, and encephalitis associated epilepsy. These hidden things, everyone thinks you look fine from the outside, but actually there's a lot of difficulties there. And I think if the child is not within a school that might not pick it up, or within the family, if it's not picked up, then that can go unrecognised. So I think it's also up to the health professionals to make sure part of that child's pathway, clinical pathway, is regular neuropsychological assessment and intervention to make sure that we can just get them the best that they can be.
Is it common for the children affected to have intellectual disability as well, on like before or after diagnosis, or what?
I don't think it's any more common in children with intellectual disabilities to get an MD encephalitis or associated epilepsy, but I think their children following will have difficulties. Yeah, some of them do have difficulties. Yeah, and again, they're more subtle, I think. So they will look like they're doing okay, but actually, as they get older, that gap between them and their peers starts to get yeah.
Oh, really?
Yeah.
Do you know what? I know what you mean. The subtleness can be the most awful thing sometimes, because people find it really hard to believe with me sometimes. Like cognitively, I have real issues sometimes. But it's so hard for people to acknowledge that is the case, because you always end up comparing patients to, comparing them, and there's always somebody better or somebody worse. And it's kind of like you have to look at that child's overall well-being, right?
We're really, really trying to find out, because the other thing we don't know really is what is the best predictor of outcome. when a child comes in either with an encephalitis associated epilepsy, other antibodies also seem to cause epilepsy. There's MOG antibodies, for example. So one clinical study that we're doing is trying to find some kind of predictive marker of cognitive outcome. And just from either from brain imaging, from neuropsychological intervention, just assessments, just trying to see if we can find something that will give us a clue as to pick out which children we really need to focus on in terms of improving their cognitive outcome and giving them that neuropsychological support early on. Because not all children will need it, but the ones that do, we want to make sure we can identify them and give it to them at the right time.
And do you also look into their overall, what's the word to use? Because I can't think of the word, but like their happiness. Because we all know children can experience depression as well.
Yeah, absolutely. I think we were doing clinic yesterday, and it's just you kind of feel quite sad because there's quite a lot of young people who are suffering with anxiety at the moment, as well as dealing with their epilepsy and other issues. And we're lucky we have a really good specialist nurse, a neurology specialist nurse who works with us and his families. And I think we try and do a few things. We have a youth support worker. So again, it's a nice person who. Nice person. That's
I'm sure they are very nice. Yes,
very nice. But, not very descriptive word, but they are lovely people who do a great job of just engaging young people, and they don't even talk about their disease. And Lydia, our nurse, said that when she refers them, she won't even say much about them. She'll just say, can you have a chat with them? And they talk about all sorts of other things. But again, it's about building confidence and just getting to know that young person and taking them, away sometimes from the worries that they're having. So we've got that. We try and do through the pandemic as well. We've been doing regular kind of patient family Zoom meetings. So that's quite nice. So it's myself and the lead of the kind of neuroimmunology service, our specialist nurse, and we'll have a topic. So we did a really good one. Well, we thought it was good about mindfulness, where our psychologist talked, and then a friend of mine who's a yoga teacher took them through a guided meditation relaxation. So that was nice. So we've been trying to do things like that. So I think, as Colin was saying about the pandemic, it's brought these opportunities that we wouldn't normally have thought of doing. So we've been able to do those kind of things. So I think, yes, we're definitely recognising that mental health plays a huge part in children's and young people's recovery and dealing with. So we're trying to address it in the ways we can.
Oh, so could you tell me what other positive and challenging parts of your roles?
The positive ones, I think, as I've said, definitely being able to see the patients and think, oh, okay, that's one of your problems. Let's see if we can sort that out, from the lab and then bring it back at some point. That's the main aim. And I think challenging is, I think particularly I'm in a really amazing lab. You've already met Gav Woodall, who leads the lab. And I think it's still challenging for me to think of myself as a neuroscientist, because I'm actually, first and foremost a paediatrician. So it's actually sometimes quite challenging to, think of myself as that. So that's why it's really nice to be in a well-supported kind of science field. And I think it works both ways. I think it's quite nice for them to have someone who's met, and treats people with epilepsy as well. So that's quite good. So I think it works quite well in that way. But yeah, sometimes that is quite challenging, because my background is obviously medicine rather than neuroscience. But I'm learning fast all of these things. So yeah.
Well, yeah, but you've been doing it for like ages. I guess one of the. Well, in my head anyway, I just think that, yourself, Gavin, you're there to make a positive difference to people affected. And if you keep that way of thinking, then you're kind of on the same path, one would hope. Yeah. And that makes things a lot easier, right?
Yes. And it's such a nice working environment. You've met Gav. It's very chilled and very supportive and a lot of fun. Yeah, so it's good.
How many people are in your lab, actually?
Well, my little lab, it's just me and my postdoc, Manos.
Cool.
brilliant. And yeah, that makes a huge difference, having literally a right hand man who's helping you do all these, experiments and things. So then, you can do other things like do a bit more clinical if you need to, for example, because you've got someone there. And so I have also a PhD student who is looking at some of our EEG data from our models, which is good. And then we have another postdoc who takes charge of the kind of clinical studies that we're trying to do with antibody-mediated disease and seizures. So yeah, so there's about 3 or 4 people within my tiny lab, but obviously we're nested within Gav's lab. So yeah.
You guys are so modest. Oh my goodness. So, okay, this is like a bit of a deep question as well, but where would you see yourself in the next sort of like 2 to 5 years or 10 years and your research? Because I think a lot of people, including some of our listeners, especially those who aren't necessarily familiar with research, are like, oh, okay, cool. So research is going to be a cure next year for all these different things, and we know that's not the case. So I think it's really important to manage people's expectations whilst inducing excitement, not too much excitement, but yeah. So where do you think we're going to be, or you're going to be, or is that it's not an easy question to answer, but
no, I think because I can see your t-shirt, does it say genetics?
It kind of does.
Brilliant, because I was going to say the great thing about epilepsy recently has been obviously the genetics revolution, hasn't it? Getting all the finding out proteins, and that's been a huge revolution. So I guess, and personalized medicine, all those things. So I guess I'm trying to do a similar thing with antibody-mediated seizures and epilepsy. So we know that specific antibodies act on specific receptors. So why can't we also use specific treatments, to help some of the symptoms? So that's what my aim is to do. And so I would hope within 10 years, there might be a possibility of, and I think other groups work on this too, so it'd be great, is to actually have specific targeted therapies that will work alongside immune therapies to kind of get to the antibodies. But you'll have specific therapies to try and trying to reverse the effects that the antibodies are actually having at that kind of brain cell membrane. So that would be my aim, to try and get those drugs to patients, because I think that if you can, exactly as the genetic research are trying to do, if you can try and reverse the consequences of affecting that protein, you might stop seizures, but you might also help improve outcomes in the long term, particularly in like developing brains of children. So that would be my hope, is we'd have at least one of these drugs I'm trying, hopefully helping patients.
And I swear, you help patients, you help their families as well. There is that ripple effect. And would you say that over time we're going to identify far more people actually affected than we realise right now, that there might be right now?
Yeah, I think you're right. I think so again, very similar to genetics, we are identifying more antibodies all the time. So, when about 10 years ago, there was about 3 or 4 neuronal antibodies. Now there's more, over 10, I think. So we're identifying more and more, which is great, because it means potentially, again, treatable. You can identify them, you know what you're doing, you can treat them early. But yes, you're right. But that does mean you're identifying more cases. Yeah.
Yeah, but that's good. If you find, it took at least 4 years for my epilepsy to be identified, or anybody noticed I was being more weird than normal. So it was like, and you can imagine, I imagine there'd be less scar tissue if if I hadn't gone for it so long. So I think that's amazing, and that's very uplifting, and further evidence why people and governments and trusts should invest more in research, because without funding we have no research. Yeah. And without research, we don't have hope for the future, and that's what we need.
Yeah.
Thank you so much for joining us. It's absolutely fantastic. Also, we were going to say thank you to Epilepsy Research UK for the funding, I think, as well, for funding your project, which has been incredible.